I saw hand raised by Rosemary. You wanted to ask anything? I saw hand raised by Rosemary. You wanted to ask anything? We will wait for 2 more minutes, then we will start our today's sessions. I'm seeing few more hand raised. You wanted to ask anything? Good afternoon, everyone. So today we are going to start our today's sessions. So today also we have two presentations. Two presentations which will be done by Dr. Arun sir and Dr. Desar. For invitees, we have invited Dr. Roko sir. Sir is a senior consultant pediatrician from Bethel Hospital, Kohima, Nagaland. Sir have not joined yet, but sir will be joining soon. And second invitees will be Dr. Himesh Burman sir. Sir is associate professor in the Department of Pediatric NIGRIMS. So these are our today's invitees. So today I'm going to start with our first topic. First topic, that one is ICU Pharmacological. And then presentations will be done by Dr. Arun John sir. Sir is a DNB SRD Pediatric in Department of Pediatric NIGRIMS. So without much delay, we will start our today's sessions. Once again, I would like to give you a reminder that please write whatever queries you have in the chat box, and at the end of the sessions, we will take up your queries and we will try to clarify your doubts. So I'm requesting you once again to mute all, and I also request Dr. Arun to proceed with the presentations. Thank you.
Thank you, ma'am. Since no one is around me for at least 2 feet, I'm removing my mask and talking during this COVID situation. So my topic is going to be on ICU pharmacology. I'm Dr. Arun, DNB Pediatrics, working as SRD in NIGRIMS. So let's start with pharmacology. So it's always, studying pharmacology, being a nursing staff or being a MBBS student or pediatrics. Pharmacology means like, oh my God, are you serious? We have to memorize a dictionary. There are so much of numericals, and there is much more than just thinking it like a dictionary, and much more than KD Tirupati. There is something called clinical pharmacology. So our discussion is going to be on clinical pharmacology, common drugs used in ICU care, pharmacodynamics and pharmacokinetics. So pharmacodynamics, to be keep it in a simple way, what a drug is doing to you, being a clinical effect, being an adverse event. So that is pharmacodynamics. A study on that is pharmacodynamics. And what is pharmacokinetics? What our body is doing to the drug. So how it is getting absorbed. What is the first pass metabolism? What is the second pass? How is this being eliminated from the body? How long it takes to eliminate? So those are pharmacokinetics. Next is infusion preparations, and the last will be doubt clarification. So let's start. First is steroid selection. So steroid, which is like commonly used, and when we get children being referred, mostly along with antibiotics, a dose of steroid is given. So coming to steroids, we broadly classified them based on their half-life. So dexamethasone has the longest half-life of 36 hours to 72 hours. Hydrocot has the shortest half-life, 8 to 12 hours, and it is very rapid onset in action. So 1 to 2 minutes. Next is prednisolone, which is 12 to 36 hours, and the onset depends on the dose that you are giving. Whether you are giving 2 milligram per kg or whether you are giving it as 1 milligram, the onset of the action depends on that. And there is something called methylprednisolone. The main differentiating point is the anti-inflammatory action in the methylpred and prednisolone. So next we will see to the HPA axis suppression. So in dexamethasone, the suppression is marked. So meaning if you are giving a dexamethasone, and you have to document it properly, because when the HPA axis is suppressed, it will be suppressed for at least 1 year. And next is hydrocot, where the suppression is mild. And in prednisolone, it is least with the morning alternate day dose regimen. And anti-inflammatory action, dexamethasone has the very potent and very selective anti-inflammatory action, whereas hydrocot is like it will mimic the body's own cortisone, which is being secreted. And prednisolone has 4 times. Mineralocorticoid action. Mineralocorticoid meaning, I mean to say, it is salt and water retention action of dexamethasone is 0. Hydrocot is similar to the body, and prednisolone is 0.8. So when it will be significant, when it goes in a higher dose, the salt and water retention property will become higher. So more the salt and water retention, more chance of hypertension. Next condition where these are used are like, if dexamethasone we preferentially use for croup. So we give it as a single stat dose of 0.6 milligram per kg, either oral, either IM or IV. We give it as a single stat dose, and its action will last for 36 to 72 hours. And we have to monitor the child for at least 4 hours in your setting to clarify that whether it is being rebounded or you need ICU admission or ward admission, depends on that. And peri-extubation also we use. And hydrocot is for acute asthma we use because of its rapid onset of action. And nephrotic syndrome in varying doses, in varying regimens, we use prednisolone. And the doses I'm not going to mention here. In all standard books, or like Harriet and Lane, or even in Nelson, we have the standard dose, or Meherban Singh, which are the pediatric drug books, we have the standard dose. The next comes to the dextrose. This is like a life-saving and reversible cause for the child not landing into coma, not leading to a permanent brain injury. So this dextrose is like must to have drug. And how will you identify a patient is going into hypoglycemia? So the first thing will be sleepiness. So sleepiness meaning the child will be alert, active, and suddenly you start seeing the child in ICU becoming drowsy, and you see he will start showing autonomic changes like tachycardia, he'll start sweating, he'll become pale, and the other irritability will set in. The hunger and lack of coordination in ICU setup in children, it is difficult. Whereas in adolescent, they can tell I'm becoming more hungry. But the other things, mainly the sleepiness, you have to detect it early. And so by definition, hypoglycemia in children, it is less than 55 milligram per deciliter. In neonates, it is different. Less than 40 if they are asymptomatic, or if they are on only mother's milk. Less than 50 if they are on IV fluid. So that's a total different thing. I'm just going to give a basic understanding. So we will stick to the children mainly, okay? And the immediate action will be, if you find such a thing and you check RBS is less than 55, you have to give 5 ml per kg of IV bolus. So bolus, I mean, you have to just push it as much as fast as possible. Over 2 minutes or 5 minutes, whatever it is, you have to push it. And you see if after 1 hour you check, or after half an hour you check, if it is still low, then you have to start something called GIR, glucose infusion rate. You will be starting with 6. So normally we will be giving DNS or isolate P depending on the age and the background electrolyte abnormality. Will select the fluid. So that 5% dextrose, which is there in this isolate P or DNS, will provide usually between 4 to 5 GIR. So next you have to make sure that 6 GIR is going. Okay. And another very important indication is hyperkalemia, where you will be giving 1 gram of dextrose per kg plus 0.1 units of per kg of insulin IV over 1 hour. So now we will see how to prepare this. So my topic is clinical pharmacology. Clinical pharmacology is not how to move next. So how to prepare insulin and dextrose infusion for a 3 kg baby with hyperkalemia. Yeah, please. Okay, and so we need to first determine the amount of insulin and dextrose needed, right? So here we saw the dose. It is 1 gram per kg of dextrose. So we need 3 gram of dextrose and 0.1 international units of insulin. Okay, now how to prepare 3 gram of dextrose? So what we have is 10% dextrose, so meaning 10 gram in 100 ml. So if we need 3 grams, it will be 30 ml. So we got the dextrose, how much we need. Now how to prepare 0.3 international units of insulin? Okay, so insulin comes in, regular insulin comes 40 international units per ml. So now we will take that 1 ml mixed with 9 ml NS. So in that 10 ml, we will have 4 units per ml. Understand? Now from the 4 units per ml, we will take 1 ml and mix with 9 ml NS, and we will get 0.4 international units per ml. So now if we take that 1 ml in insulin syringe, so insulin syringe has markings like 1 unit, 2 unit, like that, 10 units, 20, up to 40 units. So meaning 1 ml equals 40 units, and 0.4 international units, which is equal to 1 ml, equals to 40 units. So if you need 0.3 international units, then we will take 30 units from that insulin syringe. So this is how you stepwise prepare. Okay, you have to document, write it somewhere, and then when we give advice to the sisters, it will be finally you will give 30 ml of 10% dextrose mixed with so and so. You have to prepare and take 30 units mixed with the 10% dextrose, and you have to give. So anything you need to consider before giving this preparation? Yes, the insulin tubing needs priming of with insulin, because insulin gets stuck to the tubing. So 2 times you just flush with insulin, the insulin tubings will be primed, and then we can start this infusion. Again, hyperkalemia, which is a very deadly condition, but it is easily reversible. You can bring back to normal if you are able to detect it early and provide this insulin dextrose infusion. And we will see the detailed treatment of hyperkalemia in later of my presentation. As of now, my focus is on how to prepare. Okay. Now, second, it's a question. You guys can put it in the answer. So first, what is the ECG changes that you are seeing? So here you can see the first one is a normal PQRST, right? And what is the first change you are seeing here? The T waves are becoming narrow and tall. Okay, narrow and tall. Then the second change that you can see is the PR interval is becoming prolonged, P is becoming shorter. Later P gets disappear, QR is become prolonged. Then it becomes a sinusoidal pattern. So when it goes to sinusoidal pattern, it is like a very late stage. Next is like fibrillation and the child will die. So our very important thing is to identify the tall tented T waves, which is a very early sign of hyperkalemia. See, hyperkalemia is asymptomatic, but we can detect with this kind of ECG changes, and you need not always have a 12-lead ECG. Even with the normal monitor ECG, when you start finding these changes, go through the history. Are you giving any drugs which can cause hyperkalemia? Is the child having any renal impairment? So we will detect accordingly. Next, what we are going to do. So you guys have identified a drug, what we are going to give. Okay, fine, good. So next we will be seeing how to prepare this drug, right? So this is calcium gluconate, and it comes in 10% concentration, meaning 1 gram in 10 ml. Okay, so now what we are going to do, we are going to dilute it. So first we must dilute calcium gluconate. 1:1 if you're going to dilute with D5 or D10, 1:2 if you're going to dilute with water for dilution. So dose is 1 ml per kg. Suppose you have a 5 kg child, then you will give 5 ml plus 5 ml of 5% dextrose, or you want to dilute it water for dilution, then it will be 5 ml plus 10 ml of water for dilution, and you will be giving it over 30 minutes under cardiac monitor. So meaning under cardiac monitor. Why? Because this is a drug which can cause severe bradyarrhythmia, and it can lead to asystole and cardiac arrest. So now we should always do it under cardiac monitoring. So now if the child is 20 kgs, can we give 20 ml of calcium gluconate? No, because the maximum dose of calcium gluconate is 10 ml, right? And the another indication is hypocalcemia. And the picture that you are seeing here is, it is being given to a neonate, and the line was not monitored properly. The drug has got extravasated and has led to a massive gangrene and necrosis. Okay. So next, identify this drug. So what you are seeing here, you are seeing some form of tachycardia. Here we can assume that it is almost 250 to 300 beats per minute, and you have given one drug. Okay, so that is adenosine, and you see there is a pause happening to the rhythm, and after a pause, sinus rhythm comes back. Okay, so after a pause, what you are seeing, P wave is coming back. So after a pause, so don't get scared about this pause. This pause will be there for approximately 10 seconds to 15 seconds, and P wave returns, then followed by a normal QRS. So here in the first tachycardia, how do you identify SVT? This is SVT, and which is very common condition. You have to look for it. If you see the monitor buzzing like 220, 220, 220, or 180, for children it is more than 180, for neonates it is more than 220. If it is like constantly buzzing you 230, 230, 230, and it is not like 160, 180, 230, 230, 160, no. And arrhythmia, SVT, it is like you'll show a constant beep of that. Then you look into the P wave. There is no P wave, and it is very narrow complex. Then you give adenosine. Don't wait for anything, and you will get this kind of thing. It's a very miraculous drug. Or some children, they already have the card in their pocket when they come. No, they are known case of SVT, and they come with some giddiness or palpitation, butterfly sensation in the heart. So those kind of things you should look for. And the doses, first dose will be 0.1 milligram per kg. Maximum dose is 6 milligram. And if you want to repeat the dose, second dose is 0.2 milligram per kg. Maximum is 12 milligram. So what are the adverse effects you have to encounter, or when the children tell you, you should not worry much. Main is dizziness, headache, or this transient bradycardia that you are seeing, and hypotension related to that. So immediately after administering the drug, don't make the child, okay, you're fine, go walk around. Make him rest in a supine position. If possible, raise the leg up, let the blood flow go to the brain properly. And next, we will look into the pharmacodynamics and kinetics. The onset is very rapid onset. As you can see, you just administered, there will be a pause in the cardiac monitor. Duration is also very brief. The half-life is only less than 10 seconds. So this drug should reach the heart. So you tell me, where will you give the drug? You will give the drug in the leg, or in the hand, or in the brachial, or in the IJB? Like, where will you give? Okay, so it should be closest to the heart possible. Okay, so if you are able to get a line in the forearm, or if there is an IJV, go for IJV, or if you have a central femoral line already in situ in ICU, go for it. So it should be closest and directly to the heart, and you have to monitor the ECG and heart rate. And this is a drug. So now, how will you give this drug? You have the drug, you know the dose, you're prepared, you know the site also, you got it, but you know the half-life is less than 10 seconds. So average flow to the from this area to the heart is more than 10 seconds. So you need to really push something later. So first in line to the vein will be adenosine. One person will be holding this, give adenosine, the other person will immediately flush with 5 ml saline or 10 ml saline. So it should be a rapid flush technique. Okay. So next will be on the sedation, and which Dr. Anna has already covered. So I'm not going to teach you guys this. Pre, intra, and post sedation requirements already covered. But I will just tell you the pharmacodynamics and kinetics. Midazolam, fentanyl, ketamine. These drugs are very simple to administer, and the side effects are also, compared to their benefits, it's very less, and some of them are very brief side effects, and which if happens also, like hypotension, you can easily tackle it. Okay, so onset of the clinical effect is 2 to 3 minutes. So if suppose you are going to give a drug and just don't see that, okay, 30 seconds over, 1 minute over, still haven't started, so I'll go push him with another drug. No, you can wait up to 3 minutes. Okay, and the duration of action is 30 minutes to 60 minutes. So this will determine how frequently you are going to give, and if you are going to give as an infusion, and when you stop it. So when you have to look for the clinical effect that he has come out from fentanyl, suppose you want to give a morning holiday for sedation, then you have to stop it at least 2 hours before or 1 hour before. And again, each and every kinetics depends on the child's background condition, background liver problem, background this. So those things has to be taken into consideration. Next is muscle relaxant. So muscle relaxant should be used only after the child is fully sedated and child is not going to know the pain. Otherwise, he will start fighting inside. And muscle relaxants in pediatric practice, mainly it is being used if you are going to intubate the child and you have a very expert in intubation. You are going to intubate it nicely, and then you are going to take a full control of the breathing, ventilation. And for like ARDS, you need a full control. You cannot leave the child to fight with the thing. So you give a proper sedation and analgesic, still the child's brain will be provoking so much of fast brain. So there'll be this asynchrony between the ventilator and the thing. So those time you go for muscle relaxant. So vecuronium dose is 0.1 milligram per kg per dose, and these are given very slow IV over 5 to 10 minutes. Look for the effect. If you got the effect, stop giving the balanced drug, and you see when you need, you give again. Okay. So only thing is, don't just freeze me. Okay, muscle relaxation is going to freeze a child. I am awake and can still feel pain. I will not forget this later. We don't want a post-ICU syndrome to develop in our ICU patients. So next we're going to Ionic Drops. And the Ionic Drops commonly used here all have the same characteristics. First thing is, you are going to dilute with either 5% if the child is having hypoglycemia or the volume is less and hypoglycemia is you dilute with 5%, or you dilute with normal saline. And the onset of action is 1 to 10 minutes. The onset can vary from 1 minute to 10 minutes. That means you are giving an adrenaline for a shock. You may, before increasing to the next dose, you may wait till 10 minutes also. And the peak effect happens in 10 to 20 minutes. And the most important thing is, half-life is only 2 minutes, meaning you are giving infusion, you have controlled the BP, and you advise X-ray. You said, okay, you do X-ray, I'll come back and see. But suddenly you come, child may have cardiac arrest. The reason being, child might have been disconnected from the Ionic drop, and then the X-ray would have done it somewhere, or while doing X-ray, might be he would have felt it's not okay, I will adjust for myself, I'll stop. So X-ray, if he's taking for a long time, maybe for 2 minutes, 3 minutes, and that is delay in connecting back. The half-life 2 minutes is gone, and the child will drastically go into shock because there is no endogenous catecholamines to keep the BP up. So this is very important. When you are going to advise something, when you're starting Ionic Drops, starting Ionic Drops is very easy. And only thing you need to do is just monitor the BP and titrate the Ionic Drops. And never give soda bicarb in the same line with Ionic Drops. In fact, soda bicarb is never mixed with any of the other electrolytes or other Ionic Drops or any other antibiotics. It is usually given in the separate line. So first is epinephrine. So this is a very good drug in crisis. Okay, if it is typically used for anaphylaxis, and severe sepsis, or if there is any cardiac arrest, we use this drug. So what does it do exactly? It has two action. All these inotrope, they have action on the blood and the blood vessel. So in the blood, in the heart and the blood vessel, the heart has something called beta 1. Beta 1 is situated in the SA node. And what does it do? It increases the inotropy. Okay, and inotropy means it increases the force of contraction, and it increases the heart rate, and thereby it increases the cardiac output. Good. Then what happens in the peripheral blood vessel? It increases the systemic vascular resistance and BP, and in the there is bronchodilation also with epinephrine. So there is no absolute contraindication for epinephrine, because epinephrine is used when there is a life-saving situation is needed. If you're going to give us a injection, whether subcutaneous or IM, it is given for mostly for a life-saving condition. And if there is a cold shock, you start as an infusion. And this drug, if you see all this inotropes, except the dopamine and dopamine comes in a clear transparent bottle, but norepinephrine and epinephrine comes in a brown color bottle. So eptoin comes in a brown color bottle. So these kind of drugs, they come in that color bottle because they have to be protected from the light. Okay. And now when we start as an infusion, we need not wrap the drug separately. Okay. Because once we prepare this, we can use that for at least 24 hours. Whatever drugs we are preparing, only for 24 hours, then you have to re-prepare. That is very important thing. Only this effect will happen if you are just withdrawing and then just keeping it outside. Some will say, okay, it's a very small dose, so let me just prepare and keep 1 ml plus 9 ml, prepare and keep. Then after 2 days, child is having cardiac arrest. You take that same one and give, it won't work, because it has already crossed 24 hours and it is not going to work. And epinephrine shelf life is only 6 months. So you have to always update your shelf life of the drugs. These drugs have their own expiry date, and for the epinephrine, which has the shortest expiry date, which is 6 months, you need to keep that in mind and update it. Norepinephrine, this is the first Avenger, one of my favorite drugs. And most of our shock which comes is the distributive shock, which is either due to sepsis and or there will be hypovolemia due to sepsis. So these kind of things, when it happens, norepinephrine comes first. So what is the action here is, it increases the heart rate and cardiac output, and it increases the systemic vascular resistance and BP. But when you compare to the adrenaline, norepinephrine is having a very good action towards diastolic BP. It will increase the diastolic BP to a higher end. And when there is a wide pulse pressure, that means the diastolic BP has gone so low, and which usually happens in a wide pulse pressure means warm shock, which usually happens in sepsis. When you give this norepinephrine, it pulls up the diastolic blood pressure. And more detail about shock will be spoken by Himish sir. And next is dopamine. So dopamine, there are two kinds of doses: low dose and high dose. So in the when you start like 5 to 10 microgram per kg per minute, it increases the heart rate and it increases the cardiac output. But the worrying part about dopamine is it easily causes tachyarrhythmias. And we have other better inotropes, so we keep dopamine as a reserve drug these days. These days the drug of choice has become norepinephrine or adrenaline or dobutamine in cardiac cases, and dopamine has become like a second line drug. And this again needs don't use if it is darker and slight yellow. So slight yellow is allowed, the color, and it has some D1 D2 action, so it causes vasodilatation. So that means, can we use it for a pre-renal failure? You are suspecting a hypovolemic shock and pre-renal failure. Can we use it? No, because you have to correct the cause. Even though it causes vasodilatation, but when there is no fluid in your body, it will not cause a good flow. So it is not used for acute renal failure treatment as such. Next, dopamine at higher dose is very, very dangerous. What it does it just squeezes the blood vessel. So your heart is having very difficulty to pump against a squeezed blood vessel, and eventually your heart is not supported at the very high dose. And what happens? Your heart goes into failure. Okay, high dose meaning more than 10 microgram per kg per minutes. So these kind of thing with high dose dopamine can be used when you are already supporting your heart with either norepinephrine or with dopamine you are supporting. That time we can use it like an add-on drug. Next is dobutamine. So dobutamine has become a drug of choice for cardiogenic shock for its own reason. The reason is in cardiogenic shock, what is happening? The heart is not able to pump efficiently. Some problem is there in the heart. So now we need to support the heart. Yes, we are going to support the heart with dobutamine. Or if you're going to support the heart with any other inotrope also, the main difference is heart support is same. But what is happening to the peripheries? If you're going to support the heart, and the peripheries are still closed, or you're giving drug to close it more, then the heart will fail more because the heart is not in a position to work efficiently already. So here what we have to do, we are going to support the heart and we are going to open up the blood vessel. So when we are going to open up the blood vessel, the blood flow will be good, the heart also will become relaxed, and later on we can taper the drug when the primary pathology of the heart is being recovered. So now let's see how to prepare infusion. For this, there are two ways to prepare. One, we can use a formula, or we can use something called rule of 6. So rule of 6 is nothing but 6 into weight in kg equals the amount of drug in milligram in total volume of 100 ml. So any drug you take and you prepare like this, and if you are going to give at 1 ml per hour, then the drug provided will be 1 microgram per kg per minute. You can take it like a homework and you can calculate and see. Any drug, any dose you do, it will come in this form. So now the major drawback is you're going to prepare 100 ml. And I already told you this Ionic Drops have an half-life of, when you already prepare and keep for 24 hours maximum you can use. And you see most of our kids' condition, it's like only you'll be giving 1 ml per hour, sometimes you'll be giving 0.5 ml per hour. No, it's very less. So we are going to ultimately waste large amount of drug, and we will land up into a drug scarcity, right? And sometimes, you start with adrenaline and you have corrected the cold shock within 4 hours, 5 hours, you need to change. So again, the large quantity of drug will be wasted. So now we are going to modify this rule of 6. How to do? So here we are going to give the same rate, 1 ml per hour, which is very easy to set in the infusion pump, and there won't be any confusion. And the volume we are going to reduce to 10 ml. So basically we are going to prepare, if you're going to give for 1 ml per hour, we are going to prepare for 10 hours. So if you're going to increase also, it will be for 5 hours. And after that, you're going to prepare again, or you're going to change to something else if you want. So now we have different drugs with different dosages, right? So for example, dopamine, dobutamine, we will be starting with 10 microgram per kg per minute. If it is midazolam, we'll be starting with 1 microgram per kg per minute. If it is epinephrine or norepinephrine, it will be 0.1 microgram per kg per minute. So here you see the max. If it is 10 microgram per kg per minute, and for the above thing, you have to multiply 6 into the weight. If the child is 10 kg, so 6 into 10 kg will be 60 milligram of the drug you will be taking to provide 10 microgram per kg per minute at the rate of 1 ml per hour. So same thing you want to reduce. So 1 0 is gone. Then what you have to do from the 6, you have to come back 1 point. So 0.6 into kg equals to the amount of drug you need. So what if it is 0.1, then it is 2 decimals back, 0.06 into the child's weight equals the drug you want to mix to make a total volume of 10 ml, right? So now if you find that, no sir, this is not convenient, then there is a ready-made formula available. The formula is rate. So here we are going to determine the rate, ml per hour, by providing how much dose you want. For example, you want to start with 10, or you want to start with 8 microgram per kg per minute into the weight of the child, suppose 10 kgs, into 60 minutes per hour divided by the concentration. So this concentration you have to prepare. So depending on your thing, if you have a central line, you can go for a higher concentration drug. If you have a peripheral line, you will be going for a lesser concentration. So this concentration you will prepare, and when you put into this formula, you will get the ml per hour. Okay. So now let's go to the practice-oriented question. So you are in wherever health facility you are, you got a child with 5-year-old boy, 20 kg with septic shock, you have diagnosed, and you have given fluid boluses, and you have even intubated the child for the shock or for ARDS or any other reasons. and the consultant has advised you to start the following over phone. Noradrenaline infusion 0.1 microgram per kg per minute. Midazolam infusion at the rate of 1 microgram per kg per minute. Fentanyl infusion at 1 microgram per kg per hour. And a stat dose of ecronium. So now I'm not going to teach you why this all are started. Those will be covered by my colleagues. So my focus is on how will you prepare, how will you administer. Okay. So for this, question number 1: how many infusion pumps are needed? Okay. So we need only 3 infusion pumps. And do we need a central line? Okay. See, we need any shock patient, and when you're going to start on multiple infusion, the answer is yes. But you need not wait for central line. But you can always start these drugs in the peripheral line until and central line is being inserted. If you are worried about a concentration, you can make it a little bit in a diluted form, and you can start in the peripheral line. And now, regarding the preparation of this drug, how to administer. So these things are your homework. No, you will get my slides. So you go backward. You see for different infusion, different rates, so that the more you practice, more rapidly you can do, and the error also will start coming down. You know, there are different ways you can always stick these kind of formulas in your critical care area, and you can, or in your emergency area, you can always look back when you have doubt, look back and then start again. So it is not a thing to memorize or think. My class is just to make you aware that these things are available, and this can be done in this way, and it is very simple, and it can be done in anywhere. Okay. And these are my references: AAP, ALS, and BLS. Harriet and Lane. It is a very good. It is available in PDF format, where you get all the drug dosages, and few images are from Google. And Lexicon is a very vast book, where it has all the pharmacodynamics, kinetics, drug interaction, and if your hospital is able to get one book and keep, it will be very useful. The drug administration becomes so simple. You need not worry about all this error or calculation or drug interaction, adverse effects, this will happen, or what should I monitor for. Everything is nicely given in this book. Okay, thank you. And my presentation is over. So any doubts from your side, I'll be happy to answer.
Thank you, Dr. Arun, for the wonderful sessions. I have seen few of the queries in the chat box. Let me. Okay. Yes. So, as an invitee, we have a Dr. Himesh sir, and then Rosina ma'am for putting the inputs as for this topic. So, I would like to request Himesh sir to add few inputs from your side, sir.
Hello.
Yes, sir. You are audible, sir.
Yeah, I think it's nicely put. The spirit of the presentation was quite nice, and then I think the message has gone clear that there are certain drugs, but when we talk about pharmacology, we just need to talk about certain drugs that is given, how they are given, and what are to be done, not done. So I think we'll go and take questions. I think Arun, there is a question on somebody asked about how to calculate GIR. They wanted you to elaborate on that.
Okay. Thank you. We are audible. I think Himesh sir, you got stuck in between.
No,
yes.
I'm done. I think there are some. We can take questions from chat box, I think.
Yes, sir. Yes, sir. I'm reading the questions from the chat box, sir. Give me a second. I have seen. Sir, one question is like isolate P is a hypotonic fluid. So is it preferred over DNS at maintenance fluid in pediatric department?
Hello.
Yes, sir. Himesh, sir. You want to answer, sir, this?
Yeah. See, isolate P
Yes, you can answer.
used only for neonates. Our policy here is to use isotonic fluid as a maintenance fluid for anybody who is not neonate. 1 month to 1 year is a bit a watershed area. We sometimes use half DNS in these cases if sodium once starts going up, but we keep isolate P limited to neonates only. And for all other children, normal saline is the maintenance fluid that we normally use. And if there is any propensity towards hypoglycemia in any of the child, then we use dextrose normal saline as the maintenance fluid.
Thank you, sir. Dr. Arun, sir, you also wanted to add in this question? Okay. Yeah, from there also you can answer.
Okay. The next question is, how long can Visalon be given for patient with tubercular arachnoid? So it is usually for 2 months we give, and for 6 months we give, and then we start to taper over 4 weeks. So 2 to 2.5 months we give steroids for tubercular arachnoid meningitis. Yes, ma'am. The PR interval is increased after the tall T wave. The PR interval is increased. Okay. Next. Is there any?
Is there any shortcut or alternative formula for GIR? I think we can
Yes.
get that as a handout, no?
Yes.
Arun,
Yes, we have 3 formulas for GIR totally. So we will put those formulas as a handout, okay? And we will circulate in the group all the 3 GIR formula. But what we would advise is you can just stick to any one of the GIR formula, so that when the next duty doctor comes, the change and everything will be uniform. So you can adopt any one. We will send you the handout.
Yeah, Arun.
Thank
Hello.
you, Dr. Arun. So
Hello.
I think few more question is also there. But if there is a peripheral line, is there we can start until C line is inserted?
If there is, what ma'am?
Like actually for Ionic Drops, is it?
Yes, yes. If there is peripheral line, yes, you can start the Ionic Drops, okay, and you will be not concentrating it so much. You can give it in a little bit diluted form until you get a central line.
I think you got the answer.
And meaning, if you have a child in shock, septic shock, and you these days in our state, the ambulance are also maybe equipped with the infusion pumps. So you need not worry that I don't have a central line. I'll just give a fluid bolus. I won't start Ionic Drop. So first, fill the cavity with fluid. Start Ionic Drops, maybe in a lesser dilution. Start in the peripheral line. Make sure that peripheral line is intact, and you make sure the hand of the patient is stable, does not move up and down, so that on the way it does not get dislodged and extravasated. So those things you do, and you are not able to manage further, you can always refer back. And the early Ionic Drop, early filling the system with if the child is in shock, fill with fluids, then the Ionic Drops. As early you start, much better for the child. And then later we can, as the child reaches higher center, then we can insert a central line and then recalculate on things needed, and we can modify it.
Thank you, sir. And then one more question we have, can you repeat the calculations on GIR?
So actually, I do not go elaborated on the GIR calculation. So we have total 3 formulas. So we will be putting the formula, and we will be giving you example for each formula, and you can adopt any one formula that you can use in your hospital or institute.
Yeah, Dr. Arun?
Yes, sir.
Yeah, do you want to tell them what is the highest concentration of glucose that needs to be can be given by peripheral line? I think that will be important.
Yes, sir. Yes, sir. Sir, the highest concentration can be given as 12%. Above that, the child will start to develop, or the neonate will start to develop thrombophlebitis. Because of the high concentration, the endothelium will be destroyed, and thrombophlebitis will happen, and it can even lead to thrombosis embolism, which is dangerous. So 12% is the highest. And what I mean is 12% of the dextrose. I do not mean 12 milligram per kg per minute. Okay, I do not mean the GIR. It is a concentration, like 5% dextrose, 10% dextrose. So that concentration, when we prepare, 12 is the maximum.
Yeah,
12.5 is the maximum.
I think, hope you got your answer, ma'am. And then I feel like because of network issue, I'm not able to get. Ma'am, whatever you got the points from there, if you have any queries, you can ask. Otherwise, I'm going to share you PPT also.
yeah, and YouTube live link can also be shared, so you can go through that.
Yes, later you can do, but I'll request you to prefer Zoom for this session. Yes, and one more questions asked by Dr. Newstar, like for the adenosine in adult, if we are giving through IGV or subclavian, we give half dose at 3 milligram.
Sir, in children, sir, the first dose, what we give is 0.1 milligram per kg, maximum is 6 milligram. In whatever route you give IJV or subclavian, the dose is going to be the same. We don't reduce it half and give. It is going to be the same 6 milligram. And the point is, reducing the dose will affect the outcome as a pharmacodynamics. So the drug effect will not come. And at the same time, if you feel that it is directly going and hitting little bit extra, this adenosine will not cause harm if you give the little bit extra also. So ultimately, we need to terminate, and it is not going to stun the heart forever, because its action is also very brief. So you have to give the 6 milligram if you're giving through IJV or subclavian.
Yep. Hello.
Maximum first dose, second dose will be 12 milligram. Calcium gluconate should always be diluted, as I told, the dilution is 1:1. If you're going to dilute with 5% dextrose or 10% dextrose, it is going to be 1:2 if you're going to dilute for water for dilution. So water for dilution are the small package which come with the antibiotic mixing and all those things. So those things, if you're going to use that, then it will be 1:2.
And then do we do that with the pediatric also?
No. Hello. Nanuka. Hello.
We are audible, sir?
Yeah.
Yes, sir.
No, I think that's
Hello?
Dr. News. Yeah, that is Dr. Newstar who is asking about that same question on adenosine through the central versus peripheral. I think he is asking whether we do that again, do that in pediatrics. As Dr. Arun has said, no, Dr. Newstar, we don't none of our book mentions about any separate doses for separate routes. And normally what happens is children, when they present with a, usually they present with this one, SVT. And then most common route that is used in a very good vein in the upper limb that is used, we would usually hardly have a time to get a central line. So that itself will be a bit some process. Hello?
Are we audible?
Yeah. Can you hear me?
Yes, sir. Sir, are we audible? Actually, this thing like got disconnected. So, are we audible, sir?
Yeah,
okay.
Yeah.
Thank you, sir. Thank you.
So I think that question is answered. So no separate doses are advised for different routes in pediatrics. Yeah, that is all.
Okay, that is answered. No? So, sir, you wanted to answer any questions from the chat box, like what is the bolus dose of D10 in hypoglycemic neonates? This is
hello. I think Arun can take all that.
Okay,
this is 2 ml per kilo. Okay. I think you've written 5 ml for others, no? Yeah. For neonates, it's 2 ml per kilo. Okay. This one, how do we dilute atracurium? Arun? What is the question? Dr. Arun, you can come here because I think that got disconnected. Yeah. Yes. And one more question.
Please give us a second. I was reading the questions. Indications for this one also answered.
Any other questions?
Now you can. Yeah. Yeah.
Indication for calcium gluconate in newborns. So first is sick newborn of a diabetic mother and less than 32-week preterm, because most of the calcium gets transferred during the late time of the 3rd trimester. And one more is severe perinatal asphyxia. So these 3 are like newborn, just they are born, you want to give like a prophylactic, you give. And other indications are when you have a hyperkalemia, and this calcium gluconate is given for the cardiac stabilization. It is not going to reduce your hyperkalemia, but this hyperkalemia, those ECG changes which are being caused, that will be suppressed by the calcium gluconate. And hypocalcemia, you document, you have a seizure and you document a hypocalcemia, you give. Again, you can divide them into late on early or late onset hypocalcemia. So those things will be a different topic altogether. So these are the broad indications for calcium gluconate in newborn. And always prefer umbilical line. And if you have a symptomatic child requiring calcium gluconate like seizures and all, prefer to give as an infusion rather than giving it in the peripheral line.
How many minutes do we check dextrose of the initial bolus in children?
Yes. So if you are going to recheck for hypoglycemia, I would advise minimum time is like 20 to 30 minutes. So if the child is like sick, you're doing CPR and you're giving bolus, you can even check it more frequently. Even 10 minutes also you can, 10 to 15 minutes also you can check. So it depends on the child's condition. If he feels stable, then after 1 hour. Why sodium bicarbonate and Ionic Drops cannot be given in the same line? See, sodium bicarbonate is like a, when you this is an alkali which you are going to give, right? And this alkali has the property to reduce or change the property of the other drugs. So that's why we don't mix sodium bicarbonate with the other drugs and give. That is one of the reasons. And electrolytes also we don't mix because it gets a cross reaction and the sodium bicarbonate effect will go.
This topic was already covered
yes.
in the last one. No? There is one question. Can we administer muscle relaxant whenever there's asynchrony within 24 hours? I think this question was already covered in our last topic, where most centers, they would give muscle relaxant in the first 24 to 48 hours, but your monitoring has to be very vigilant, because if the tube gets blocked, if anything, then the child will not be able to breathe on his own. So if you're sure that your your monitoring is good, then you should be able to, you can use muscle relaxant. In our center, we rarely use it. We rarely have to use muscle relaxant. So again, it depends on your center. If you have, if that's your protocol, you can use it. Nothing, Himesh, if you want to add, sir, if you want to add anything on this question, I think the last question we have.
Hello, Himesh sir.
Yeah, I missed the question actually. I got logged out.
Okay, okay, sir. Sir, question is like, can we administer muscle relaxants whenever there is a asynchrony within a 24 hours?
No, absolutely not. Muscle relaxant are a very reserved drug, and they can again contribute to ICU myopathy and all symptoms. So muscle relaxant has to be used for only reserved indications like a severe ARDS, as Rosina was telling, in first 24 to 48 hours. Not just in any case there is an asynchrony, you cannot use muscle relaxant. You have to look for the cause of asynchrony. First thing, you can increase your sedation. And second thing is, when you are using muscle relaxation, you have to be sure that the child is sedated enough and child is receiving enough analgesia. Otherwise there is something called as jack in the box effect, where the child will be trapped with the muscle relaxant. He'll be feeling everything and not be able to even communicate or give indication that he can feel everything. So so use it very sparingly. We use it very sparingly. We use it only for those limited indications. And I would advise that if you are starting a newer ICU, or if you're not in a level 3 ICU, then I think you should also use muscle relaxant very sparingly.
Thank you, sir. I think we have not seen any more questions in our chat box. So any participant, if you want to ask any queries, please raise your hand, okay, so that I will unmute you and you can ask. Otherwise, we are going to move ahead to our second presentations, which will be done by Dr. Desar. Wait a minute. Give me a second. Okay. Give me a second. I'll just. Give me a second. So next presentation is on the stages of sepsis, and presentations will be done by Dr. Desar. Dr. Desar is the SRD pediatric in Nigrim. So without much delay, I would like to request Dr. Desar for the presentations. Thank you.
Thank you. It was a nice presentation already done by Dr. Arun. Since some of us must be having duty right now at present, and some people who have post-night duty, and some of them who had to watch football last night, I guess it'll be more tiring for them as the talk is long. So I'll be talking mainly about just knowing about the sepsis and stages, definition, in a very summary way, like how to understand and how to diagnose sepsis. Okay. So without much delay, and I will start my slide. Okay. This is our topic we will be covered in this case. We will have a case, one case scenario, and then we'll talk definitions of some of the sepsis related topic, and then organ dysfunction and the criteria associated with it, how to know which organ has involved, and different type of shock. Okay. So our main objective is to how we will understand about the sick child, and to have more idea about the term which especially when the doctors or consultant during rounds, or anybody when they talk about some of the terminology. So the most important, we should know and understand what do they mean by the term which they use. Okay. Yeah, that Paul will. Okay. Here's a question. Have you encountered any sick child? I mean, like anybody who's very sick, maybe in your health setup, maybe PHC, CHC, or maybe tertiary hospital. If you have, please say your answer will be yes or no only. And how many of you have received? Okay. Then have you ever been treating this type of child? Okay. What giving care, or maybe sister helping the doctors in treating all those? And then what is your idea on sepsis? What do you think sepsis can do? Sepsis, is it just any other disease which can be treated easily, or is it a disease which is very serious that we have to take care of? Okay, it's good. I'm going a good response for this. Quite a lot of people have encountered a sick child. Quite a lot of people also have giving care also is very good. Okay, and good amount of answer also think that the sepsis can kill. Okay, we will go to the next slide now. Okay, we will start our talk. On understanding the terminology about sepsis. Okay, fine. Let's have one case first. One case, we have a 2 years old male boy came to our emergency, and then a doctor is talking to the mother, and the mother is giving a history that my child has started having cough 4 days ago, and then after that, after having cough, then the next day, that means for the last 3 days, my child start having fever, and then the doctors will ask whether whether there's any variation with time, or morning or evening rise of temperature, or any specific time which temperature is there, fever is there. Then the mother say no, anytime it come. And then mother also said, like, I have seen that before, even though my child have fever and cough, but still he's active, playful, but for the last 1 day now, he's not playful and he's not taking food also. I have to force him. He's very irritable. He used to cry, and then he don't want to take feed also. Okay, then the sister will come to you, to the doctors, and then they will say, sir, this vital I got, the heart rate is 146, respiratory rate is 44 breath per minute, and then the sister will feel the pulse. Yeah, the sister says, yes, yeah, I can feel the pulse, but if I feel very high pulse, big pulse, bounding pulse for a child of his age. Then she said that I've measured the temperature also is 101 degree Fahrenheit. And then she said, like, when a patient came, I checked the SpO2, it was 90%. And after that, when I give oxygen, it became 99%. But she gave oxygen with face mask. And she said, like, I measured BP also, it became 70 to 70 by 36 mercury. She said she measured in the right arm. So for this age, I'll be talking in detail about this rough estimation of expected systolic blood pressure according to age. But according to this age, we expect it to be more than 74 for a 2 years old. And then she said that the sister said, like, his sugar is also very high. So what do you think about this condition? That is this okay, acceptable this for a 2 years old, or there's something wrong with his vitals? Then as a doctor, you have to think about it. Then when you look at the vital, you see that, okay, fine, yeah, heart rate is high, respiratory rate is high, yeah, febrile is there, and then SpO2 was dropped in that in room air. And so also the blood pressure and sugar was also high. Okay, so just remember, keep this question, this case scenario. We will have ending conclusion of our. Okay, we have some question also in relation to this case scenario later on in the last part. Okay, so these are the topics. These are the definitions of different terms which I will be covering today. One is infection, the systemic inflammatory response syndrome, sepsis, septic shock, multi-organ dysfunction syndrome. Actually, in 2016, this severe sepsis is not anymore used. Previously, we have sepsis, severe sepsis, and septic shock. Okay, but now from 2016 onward, this severe sepsis is not there, but still I'll be covering it. So severe sepsis, the term which we used to use for severe sepsis, it has been added up to sepsis and to septic shock. So it's not the terminology, I mean, like the criteria, the involvement of the system and all, which has been added, used in severe sepsis. Now it has used it, sepsis and septic shock. I hope I'm not very fast. Everybody can catch up with the speed of my talk. Okay, we'll carry on with infection now. We'll start with infection definition. A suspect or a proven infection caused by pathogen or a clinical syndrome associated with a high probability of infection. What does that mean? That means any case which is suspect there is a involvement of infection, pathogen mean can be anything, maybe bacteria, maybe virus. Okay, evidence of infection including positive finding, for example, on clinical examination or maybe imaging studies or maybe laboratory tests. For example, like on clinical examination, we might get PTK, purpuric rash, or maybe pustule, purpura fulminant. Okay, or maybe in imaging study, we can find a chest X-ray, which is there is a pneumonia. Okay, and then or maybe the obvious perforated viscous chest, viscous. Okay, so that means obviously the infection can enter from that. And then leukocyte in abnormal sterile body fluid. For example, in this one, like for example in CSF, we don't expect there to be leukocyte. But yeah, for different in pediatric, in different age group, we have different. There are upper limit where we can still accept, but if it is more than that, so we cannot accept. So that's why we don't. We have to also carry on with the age limit also. And the most important of all is to prove that the obvious infection is there. Any positive culture, maybe due to blood, or maybe due to culture from your throat swab, or maybe from the maybe some simple pus, or maybe pustule which is there from in your hand. You culture that positive culture. That is a definite, the most golden standard. Okay, positive culture. And now I'll be talking about systemic inflammatory response. In systemic inflammatory response, the presence of at least 2 of the following 4 criteria, but the most important is the involvement of abnormal temperature and leukocyte count, maybe increase or decrease. Okay, so the criteria I'll be showing now, but the most important, at least 1 of these following should be there. Keep that in mind: abnormal temperature and leukocyte count, which either high or low. Okay, so one of the criteria should be core temperature. Temperature may be hypothermia is there, or maybe hypothermia. Okay, and then tachycardia or bradycardia. Tachycardia mean in absence of any stimulus. Stimulus mean like maybe the patient is in pain, maybe you put the patient in ventilator, or maybe it's a distress. Patient is having distress with the mechanical, or maybe the support you are giving, or maybe the patient is having simple pain from your anxiety also. So that those are the things, stimulus you should exclude first before saying that it's a tachycardia. Okay, and then for example bradycardia, in absence of any stimulus, maybe for example like using of beta blockers, or in case of heart block disease. So those are the conditions that you have to rule out first, and then yeah, before you say it's a tachycardia or a bradycardia. And then tachypnea, obviously when the patient is having respiratory distress and fast breathing. Okay, and then leukocyte count may be elevated or depressed according to the age. After the SIR, systemic inflammatory response, now I'll be talking about sepsis. Sepsis mean systemic inflammatory response syndrome in presence of proven infection, or maybe result of a suspect proven result of a infection. So that means SIRS is together with infection. Infection has to be there, so that systemic inflammatory response systemic inflammatory response should be together with infection, then only we can call it sepsis. If there is no infection, that means it can be, if there is no infection, that means it can be only systemic inflammatory response. That means response maybe just be high temperature, or maybe tachypnea, or maybe tachycardia, but maybe due to what? Just as simple as maybe pancreatitis, or maybe due to any other which is making the patient discomfort. Okay, it is defined based on the presence of systemic dysfunctional host response that lead to organ failure, okay, or life-threatening organ dysfunction caused by dysregulated host response to the infection. What does this mean? This means that there is a systemic problem overall the whole system, where the system cannot properly maintain or respond well toward the infection. Okay, what does this did? It caused the infection caused some abnormality in the function of the system. So this whole line is it mean as simple as that only. Okay, so it can cause organ failure or maybe life-threatening, because why? It's due to the infection. That is sepsis. Okay, the criteria for sepsis: suspect or proven infection, an increase in a sequential organ failure assessment. Okay, a score of any this one first as soon as the patient came, this is your first first you review the patient, and like in emergency, if there is a altered mental status like tachypnea or hypotension. For example, you remember our case, the patient came with irritability is there, tachypnea is also, hypertension is also. So this patient, that means from our case which we already showed you from before, that means he's having this he's fulfilling this criteria. And any criteria which is more than 2 or high, more than 2 or equal to 2, that means that patient is having poor outcome. That means the patient is serious. So now I'll be talking on septic shock. Okay, that is the general idea only of sepsis, SIRS, and infection. So in septic shock, a child with sepsis, presence of hypotension. So now I will tell you general in fast track, in fast track, how to calculate the systolic blood pressure of a patient. If the patient blood pressure is 70 millimercury in infant, or 70 plus 2 times the age after 1 year. So that will give you the rough idea about the systolic blood pressure. Okay, so septic shock means in the presence of either the presence of hypotension with the need of vasoactive to maintain the blood pressure above the fifth centile. Okay, so then keep that in mind. There will be a need for the use of this vasoactive so that you can maintain the blood pressure of the person, of the baby. Okay, next, signs of perfusion. Sign of perfusion. So what do we have? One is hypotension. Okay, another one is which we have is the need of vasoactive, and another one where there's a sign of hypotension. That means maybe the BP is fine, like Dr. Arun has already mentioned that means there is a BP is fine, there's a systolic and diastolic gap is there, and peripheral pulse is also felt, but it's not but you think that baby is fine, but actually there is something wrong. In case of hypoperfusion, like any three of this following which I'm going to tell you, like decreased pulse volume, then maybe it can be weeks or maybe it can be present. Okay, capillary filling time more than 3 seconds. But you have to exclude that the child is cold, because we tend to have the child, cold periphery and all, but we tend to take child come with hypothermia, and then we tend to take it as a septic shock. But make sure that the child is warm. You have to rule out that one also. Okay, and tachycardia, core to peripheral temperature, there is a gap of more than 3. So here you make how much is the hypothermia of the child also and presenting, but if it is more than 3, that means it's definitely suggestive you about that the patient is in shock. It most probably due to septic shock and with decreased urine output. So this will tell you that this is the decreased perfusion due to hypotension, or maybe due to sepsis within the body, that that the volume or the body, the vital organ are not getting proper perfusions of blood. So septic shock is a subset of sepsis in which the underlying circulatory and cellular metabolism abnormalities are profound enough to substantially increase mortality. So here in a septic shock, that means there, like sepsis, SIRS is there with infection, sepsis. Now sepsis in presence of metabolic abnormalities. That means the vital organs are not able to function properly. Okay, and this SIRS and sepsis has profoundly affect this vital organ, so it can lead to more chance of mortality if we don't treat the person fast, if we don't take action fast. Okay, so another one, the criteria which is very important to include to tell that okay fine, this is a sepsis or this is the septic shock. Sepsis plus vasopressor therapy required to maintain the mean arterial pressure more than or equal to 65 millimercury and a lactate of more than 2 millimole per liter despite adequate fluid therapy. So what does that mean? That means your mean arterial pressure is high, and then after you give so much of fluid also, you like your ABG, you see that your lactate is still more than 2. That means and there's a requirement of after giving so much of fluid and still there's a lactate is high, and there's a requirement of vasopressor to maintain your BP. That means this is a septic shock. Okay, so as I told you, severe sepsis is a condition where which in 2016 they have used it out, but I'm just telling you to outline what actually severe sepsis is. It's a cardiovascular disorder associated with any one of this acute respiratory distress or 2 or more organ dysfunction. So like this, we already covered it in case of sepsis, dysfunctions of the organs, and then due to in response to the infections, and then in septic shock, that profound vital organs which dysfunction, which can lead to mortality of the patient. Okay, so overview here. See here, what you will understand from here, from this slide is the infection alone. It can be maybe due to fungus or virus or maybe parasite or any others. Okay, and the most important cause of the sepsis is always with bacteria, which is caused mostly by bacteria only. So another here, you should not keep in mind that you should not remember, keep that in mind. You should not keep in mind that SIRS is caused only by infection, mean in association of infection. Okay, why I keep this slide also, so that you'll understand. You look at this circle here. SIRS can be caused by any others which is not related with infection. Okay, due to inflammatory condition which is present within the body. Okay, maybe some autoimmune disorder, maybe in case of pancreatitis, or maybe in case of burn. Okay, maybe in case of trauma, this can cause self-inflammatory response of the whole system itself. For example, in case of burn, there will be an open wound. So this open wound will get infected by the bacteria, and then so inflammatory response is already there from this burn, and then infection by bacteria now is already proven infection with inflammatory response. So it will be included in that single elliptic shape. It will be sepsis now. So this is how the overview. You should understand that SIRS is not always associated with infection only. It can cause by any others, or maybe SIRS, simple SIRS, then with co-infection, which can cause sepsis. So now we'll talk about the multi-organ dysfunction syndrome. Okay. The detected of altered organ function in an acutely ill patient constitute multiple organ dysfunction syndrome. Okay, so just keep this in mind, that any more than two, okay, or equal to more than two or equal to involvement of organ, that will be multi-organ dysfunction syndrome. Okay, in organ dysfunction, we will talk one by one, especially our vital organ. Okay, cardiovascular system mean hypotension, like which I already mentioned, less in 70 millimercury in the infant, or maybe 70 plus 2 times the age, and still we don't get our expected rough. This is rough calculation. Keep that in mind. This is a rough calculation for your systolic blood pressure, and then there's a need of drugs to maintain vasopressin, vasoactive drugs for the maintain the blood pressure more than 5th centile. Sign of hypoperfusion, which I already mentioned just now in my previous slide, decreased pulse volume, capillary filling time, then tachycardia, and the heart need to pump out more so that the others organ also will get the blood supply, and then cold temperature, urine output. And then, so in cardiovascular, in early stage, what actually happened there in early stage in the cardiovascular dysfunction? In early stage, there's an increased heart rate and poor peripheral perfusion, okay, in the form of weak pulse, or maybe just increased capillary filling time, okay. And then in the late condition, what happened is, so in this early condition, your BP will be fine, and then you will just have tachycardia, and with your CFT prolonged. But in the late condition, you will have the hypotension, and if you don't treat this hypotension with all this, and the heart will keep on contracting without not enough fluid and not enough this thing, so it can even lead to cardiac arrest, which is the final stage. Now I will talk about the respiratory dysfunction. So in respiratory dysfunction, there's a proven there's a need of oxygen supplement. For example, you give FiO2 FiO2 maybe from the mask, or maybe from ventilator, or maybe from in CPAP, or as well, like previous class is already covered, where FiO2 is more than 50%. To maintain a saturation of at least more than at least or more than 92%, that means this patient is sick. He is required oxygen supplement. He is very sick if he has required more than FiO2 of 50% to maintain his saturation. And then need of non-elective mechanical ventilation. Need all of a sudden intubation, or all of a sudden requirement of CPAP, which we are not planned to accordingly, for the like sudden deterioration in the respiratory. That means in the oxygen saturation and all. Okay, and then if you take the ratio of PaO2 participation of oxygen and FiO2 less than 300. Okay, but the most important here, in absence of any pre-existing lung disease or heart disease. So what does that mean? The patient which you expect to be, there is no history of any heart disease or any history of lung disease, which is completely fine. And all of a sudden his ratio became less than 300. This is also suggestive of respiratory dysfunction. And then you do a blood gas. You ask for this, your sister or your colleague or maybe in ICU to do a blood gas for a patient, where actually there's a typing mistake here, where this thing PCO2 is more than 65 or maybe more than 50 to 55 millimercury. Torr and millimercury almost equivalent, only the calculation here. Some machines say give torr or some machine give millimeter mercury. Over the baseline of your PCO2, mean baseline PO2, which is I think is which is already covered from previous class, that it should be around 20 to 40 or like that. If it is more than 50, that is not acceptable. That means the respiratory failure is there. So this is all suggestive of your respiratory dysfunction. Neurological dysfunction, a Glasgow Coma scale of less than 11, or maybe there's acute loss of GCS, mean acute deterioration in your GCS, which is more than 3 from your base point. So an admission, you have GCS, let's say 12, and then by the time you reassess the patient is already 9 within 1 hour or maybe within 2 hours. So that shows that okay, he have some neurological involvement also, which is deteriorating his well-being of the patient. Okay, so here in the slide you will you can go through later on how to assess the difference between in child and infant. Their Glasgow Coma scale, how we calculated it. And hematological dysfunction, here the platelet count will be less than 80,000, and there's a decline in 50% in the platelet count from your highest record. This means, for example, on admission the patient came, your platelet count is 1,50,000, and then by the time you reassess the patient after after 3 days, and you saw that all of a sudden a drop is there about 60% of the 60,000 platelets. So that means this is something is there in his which is related to the septic shock, or maybe something sepsis is going on. That's why his platelet is having thrombocytopenia. Okay, and then an INR ratio of more than 2. So this was all also associated with sepsis only. Renal dysfunction, serum creatinine more than 1 milligram per deciliter in children, or maybe urine output of less than 1 ml per kg per hour. For example, a 20 kg, he have for 1 hour, he have only 20 ml, less than 20 ml in 1 hour his urine output. After in a strict urine output monitoring child, then you understand that okay, fine, he's having renal dysfunction. Hepatic dysfunction means where there's a increase in bilirubin more than 4 milligram per deciliter, but make sure you know that in a neonate you don't take this as a calculation. Okay, in neonate they tend to have high also. So we used to have a phototherapy range. We have a range for children from where to start the treatment and all, and exchange range if it is too high. And then the alanine transferase, which is more 2 times than the upper limit of the normal age. Those are the things. So any involvement of any system from the above mentioned system, any 2 or equal to 2, at least 2 or more than 2 involvement, that means the patient, you can label him as a multi-organ dysfunction syndrome. This one also I will not be talking in detail. It will be talking in detail by Dr. Himesh later on in the class. I'll be just giving you the hint, the rough idea about what are the different type of shock. So we'll start with hypovolemic shock. Hypovolemic shock means characterized, it's due to the fluid loss. Fluid loss can be as simple as maybe diarrhea, or maybe vomiting, or so this will lead to decreased preload. So first response, what will be the first response of the heart? There will be tachycardia, and systemic vascular resistance will increase. Why? Just to bring more fluid toward the vital organ. And then if still this hypovolemic shock is not treated, so what will be? It will lead to hypotension and then tissue ischemia and further deterioration. So involvement of different organs. So it can lead to multi-organ also, just as simple as due to hypovolemic shock. The treatment and management will be covered in the next class. I'll just give you the idea about this term. Distributive shock is a state of abnormal vasodilation. That means in this thing, there's a condition in the peripheral vessel. There's a vasodilation, especially like what we see in sepsis. We say warm shock. So this is a condition like why? Because vasodilation is there peripherally and the blood distribution is there quite quite okay. So patient will be warm only. So in which condition and then so what happened here is in another way is the systemic vascular resistance here peripheral vascular resistance is less. So there will be hypotension also. Okay, so in which condition we will see this condition, this distributive shock is in sepsis, or maybe as simple as hypoxia, or maybe poisoning, maybe anaphylaxis like allergy, or maybe or spinal cord injury, or mitochondrial dysfunction. Distributive shock. What actually happened is, you see, it's lowering the systemic vascular resistance initially, and then finally it decreased both the preload and afterload. Because why? Blood venous return is less due to pooling of blood toward the organs or maybe toward the periphery. So there will be what? There will be decreased blood return. When there is a decreased blood return toward the blood, this is what it is. Decreased preload, and then since there is decreased preload, there is not enough blood to pump out, so it's also cause decreased afterload. So that's why we have the especially in sepsis, the MAP is very high. In cardiogenic shock, maybe it can be associated with this condition. Is what happened is the heart is not pumping properly, so maybe it associated with myocarditis or congenital heart disease or arrhythmia, or maybe as post heart surgery. So here the myocardium is not the contractility of myocardium is affected. So there will be both dysfunction of systolic and diastolic. But what we actually see most of all of the shock, either hypovolemic, distributive, or septic shock, or these are all, they will all have their final effect. The heart will always be the will be affected only. The myocardium will get affected only. Cardiogenic shock will get involved only. So septic shock. Septic shock, like I already explained to you about those involving with infections and then SIRS, okay, and need of vasopressor. That septic shock in my previous slide. Here is a unique combination. There's a combination distributive shock also. It can be like I already mentioned it just now. Maybe it's associated with volumic shock, or maybe it will be in combination with cardiogenic shock. So that means fluid resuscitation also you have to give, vasopressor also you have to give. Okay, and then maybe and the most important is associated with the inflammatory response or due to infection. We'll have one more question. Just remember the last the slide which I had in the first two slide question about that child who came to emergency. So what will be your answer? Just a second. Yeah. So for that child which came to us, which came to our emergency, and then doctors also have seen, staff nurse also have seen the condition. So what do you think about this? Do you think that the child need to further evaluation, or I think it's okay, he doesn't need to, or maybe we'll just treat him and send him home? Okay, according to the answer which I get till now, it's like everybody, that means has understand the topic properly. Everybody has given the correct answer. Okay, some just start giving. Okay, no problem. It's good. Most of you understand the topic. Take 1 minute. Yes. Okay. Yeah. So this we'll just go back to the question which I had, that patient which came to our emergency. So okay. So this patient who came 2 years old male who came to our emergency, he does need admission. He does need further workup. He does need a proper aggressive treatment also, or else, because this patient he's in septic shock. If we don't treat him aggressively now, fluid, vasopressor, and all the requirement, patient can go to arrest also, can be very bad outcome for us if we don't treat immediately. So this patient with this symptom, with this symptom and with this vital condition, we cannot send home. We have to treat him in hospital. With this, I finished my presentation. I hope you understand the terms which we commonly use in general view. My sources mostly used from Indian Journal of Critical Care of Pediatric and Tintley Book of Emergency Medicine, and from Nelson as well. Any question, please?
Yes, before moving to our questions and answer, I would like to request Dr. Himesh sir to add few inputs from your side, sir. Yes, sir.
Yep, Dr. Desai, congratulations, nicely done. Presented well. The purpose of this talk is to basically make you aware that there is a different spectrum, I mean, a whole spectrum of condition that is available associated with sepsis. And secondly, that when you have a systematic inflammatory response, it's not always need not necessarily be because of an infection. So you need to, when you say sepsis, then you need to know that there is a systemic inflammatory response, and there is a documented source of, or at least a syndrome that is associated with a infectious disease. So that is important. So if you do not have an infection, or you do not suspect infection, but if you have SIRS, then that is not sepsis. And this is important because we spoke about rational use of antibiotics also earlier. So based on that, it is important. Dr. Rosina in her talks also earlier have been talking about picking up a sick child, stabilizing. So this child, what he gave showed in our topic now also, the sick child. So you need to assess this child, stabilize this child first, and then further management will happen. And just one more comment on what Dr. Desai was talking about. In any type of shock, ultimately the heart gets affected. So it's like that, as he has shown, that shock can come early, then it can progress to a decompensated or hypotensive shock, and if it not corrected at even in this stage, then it goes to a stage of multi-organ dysfunction, and in this stage the heart also becomes a victim. So our aim is to pick up shock even before the child is in hypotension. So pick up shock early, so that we can treat a shock early, so that in every case heart or any other organ does not need to get affected. Okay, so we will discuss about more about this in our next class on management of shock. So that is all from my side. We can take questions, I think.
Thank you, sir. Thank you so much. So one question is asked by Jacinta ma'am, like, what does it indicate a lactate high? So these questions I would like to ask Rosina ma'am.
Where is it? It's audible? Okay. So what we mean by lactate, when the lactate is high, basically what happens is when we talk about shock, we talk about like perfusion. Okay, there's some problem with your diffusion. You get lactate when you have like an anaerobic process in the body, and this only happens when you have there is some problem with diffusion of oxygen into the cells. Okay, so when you have less oxygen diffusion because of either perfusion or less oxygen carrying content in the blood. Okay, so when we're talking about, especially in this context, we're talking about shock, there's less perfusion, less blood supply to the tissue organ, hence there is less oxygen supply to the tissue. So this cell at the cellular level will be able to, they'll undergo an anaerobic reaction, and they will hence give you a high lactate. So this is basically one of the indirect means of monitoring whether your perfusion is all right or not, whether your blood supply, oxygen supply at the tissue level is adequate. I think that's all from my side. I don't know if I think it's okay. Yeah, that's it only.
Thank you. Thank you, Rosina ma'am. So there is a one information from Himesh sir, like all site where you are planning to take care of sick children, sir is requesting you to get a pediatric size BP curve, either manual BP as well as NIBP. So that is a small information from Himesh sir. And then I think I have seen one more questions asked by Vamfir. What is the most common type of shock you encounter in NIGRIM's emergency department? Sir, you want to answer? Yes.
So in regard to pediatrics, we most commonly see septic shock only. So either children coming with sepsis or even with localized features. So we get septic shock most commonly. Then we get hypovolemic shock in cases of diarrhea. Then we also sometimes get obstructive shock, like at presentation, like cardiac tamponade. Then in ventilator, sometimes they develop tension pneumothorax. So we get these shocks also. We have got a couple of types of shocks with anaphylaxis or in response to penicillin in rheumatic heart diseases. So we see all kinds of shocks. Most common by large would be septic shock.
Yes, Rosina ma'am, you want to add?
Yeah, well, we get, is that okay? Yeah. We get all types of shock, like what sir had said, but then even other shocks, like your cardiogenic shock, even your neurogenic shock in our patient with CNS disorder, also we see. But most commonly is septic shock, and then sometimes even hypovolemic shock also can be missed when you have patients with diarrhea, they're not corrected, and we do get referral because of the what do you call, insufficient, on there's no correction of the diarrhea, and the child comes to us with hypovolemic shock. And I think this can be picked up and treated at any level by any medical officer. Any nurses should be able to pick up at least hypovolemic shock.
Thank you so much, ma'am. So Virendra sir have request to us, like, could you please share your experience on shock in MISC? Sir, you want to answer this one? Sir?
Yeah, we are yet to
you are not audible.
encounter. Hello?
Okay.
Can you hear me? Yeah. So we are yet to encounter too many MISCs. We have encountered only one MISC till now, and then thankfully the child did not have shock. So, however, for what is the guidelines for management of shock are that in MISC, these are mostly cardiogenic shock. So you would need to go for a slower volume resuscitation, 10 to 20 ml per kg. Over 30 minutes, one bolus is given, and you may need Ionic Drops. You have to treat most of these as a cardiogenic shock. But in terms of experience, we do not have any first-hand experience. We have not seen too many MISCs as of yet.
Thank you so much. Sir, till now, I have not seen any more questions in our chat box. So any of our participants, if you wanted to ask any question, please raise your hand so that I can unmute you and you can directly ask to our expertise. Thank you. I think Virendra sir is commenting. Thank you, sir. Okay. Anyone wanted to ask? I have not seen any hand raised. Yes. Okay, I think Dr. Arun sir and Dr. Desar sir have explained wonderfully, so that I have not seen any more questions in our chat box, and then I have not seen any hand raise also. So if there is no more questions, then we would like to end our today's sessions. We are on time. So before ending, I would like to thank you, Himesh sir, for giving so many inputs to our participant. And also I would like to thank you, Rosina ma'am, for supporting us. And for the most, I would like to thank you, our two presenter, Dr. Arun sir and Dr. Desar, for in a busy schedule also, they are running here and there, even though they are preparing PPT and they are doing procedure in between also and doing presentation also. So thank you once again for your input, for your hard work, both of you. And last but not the least, I would like to thank you all the participants who are consistently presenting with us. So still at the end of our session also, we have 417 participants. So thank you once again for having a patience and listening to our presentations. So whatever materials, as always, I will share you in your WhatsApp group also. So thank you once again. Thank you, everyone. So I think I will end. I have not seen any questions. Thank you. And pre-test post-test link I have given in chat box, as well as I have given our feedback link. So we are waiting your feedback, because after every sessions we sit together and see yours feedback, so that you know how can we improve next time. We do every time. So I request everyone to give your honest feedback to us. Thank you. Thank you, sir. I think we will end. Okay. I'm only getting a thank you, sir. Thank you, ma'am. Thank you once again.